Good evening, everyone. On behalf of the ACNS, it's a great honor and pleasure to welcome all of you to the first ACNS Medical Students and Residents webinar. My name is Dr. Evelyn Vela Rojas. I am neurosurgeon from Peru. I am truly honored to serve as the chairs of today's session. First of all, I would like to express my sincere gratitude of the ACNS team and Professor Yoko Kato, whose vision, leadership, and dedication to education has made this initiative possible. Today, we have participants from several regions of the world, reflecting the international spirit of the ACNS. I hope this will begin of many inspiring collaboration in lifelong friendship. Today we have 4 speakers. The first is Dr. Turnwell Kenalemang. Is a Doctor of Medicine in Lusaka Apex Medical University in Lusaka, Zambia. With the topic is peripheral nerve injuries in Africa, epidemiology, challenge and emergency and surgical solutions. The second speaker is Dr. Twiza Chard. She is Neurosurgery postgraduate fellow, Wenzhou Medical University in China. She is from Zambia. With the topic Trigeminal Neuralgia, the third speaker is Dr. Richmond Assi. He is a resident of neurosurgery in the Central South University, in Yunnan, in China, from Ivory Coast. With the topic is the pathways of neurosurgery in China. And the last speaker is Dr. Cebolenkhosi Mndzebele. He is a young neurosurgeon of Luka Apex Medical University from Zambia. With the topic is blood supply for the brain. Our discussants are, for discussion, Dr. Gabriel Yang. He's a neurosurgeon, a PhD candidate in neurosurgery in Bundenko National Medical Research Center of Neurosurgery in Moscow. He's from Russia. The second is Dr. Alexander Josutan. He's our neurosurgical resident and neurosurgical study program in Pelita Harem University. He's from Indonesia. And the third discussion is Dr. Janet Nunez. She's a neurosurgical resident he's a Católica Santa Maria University in the Carlos Alberto Seguin Escobedo Hospital, Arequipa. She is from Peru. And Dr. Tatiana Banks Bisheko. She is a PhD candidate of the program in neurosurgery in Bundenko National Medical Research Center of Neurosurgery in Moscow. He's from Russia. And Dr. Turnwell.
I think it's over.
Yes.
Yes, okay.
Okay, thank you. So I would like to say good morning, distinguished professors, consultants, residents, and colleagues and guests. So today I would like to introduce myself. My name is Dr. Turnwell Kenalemang. I'm from Botswana. Botswana is the southern part of Southern Africa. We are best known for our diamonds, and I'm currently in Zambia. And today I would like to discuss a topic that often receives far less attention than traumatic brain injury or spinal trauma, and yet produces very enormous disability across our continent, and that is peripheral nerve injuries. And I have the pleasure of having joined the diploma in peripheral nerve surgery for ACNS, and I've really learned a lot about this particular subspecialty. So when we think about neurological disability in Africa, our minds often go to stroke, traumatic brain injury, hydrocephalus, epilepsy, or spinal cord injury. But however, every day across Africa, young men and women sustain injuries that leave them with flail limbs, chronic neuropathic pain, and permanent loss of function despite otherwise surviving their trauma. And that's why peripheral nerve injuries are very unique because, unlike many neurological disorders, they are potentially reversible. And the difference between recovery and lifelong disability often depends on timely diagnosis, referral, surgical expertise, and rehabilitation. So, in this presentation, I will examine the epidemiology of peripheral nerve injuries in Africa, discuss the major barriers to care, and explore emerging surgical solutions that may improve outcome across the continent. So, why peripheral nerve injuries matter? So, peripheral nerve injuries, they represent one of the most disabling consequences of trauma. Unlike a fractured bone, where healing may occur predictably, peripheral nerve injuries, they initiate a race against time. And once a nerve is injured, denervation begins, right? And muscles lose their neural input, motor end plates, they tend to deteriorate, and eventually irreversible fibrosis then develops. And the result is that the patient may lose the ability to work, to care for themselves, or even participate in the society. So you find that in many African communities, this has consequences extending beyond the individual. You find that a young father who loses upper limb function may be unable to support an entire household because they're the only breadwinner. And therefore, peripheral nerve injuries should not simply be viewed as a surgical problem, but they are a public health problem. They are economic problems and health equity problems. And hence, that's why they really do matter. And just to get a glimpse into the historical perspective, so to understand modern management, we must briefly revisit the foundations of peripheral nerve surgery. So in 1943, Sir Herbert Sidon introduced three categories of nerve injury, which is neuropraxia, axonotmesis, and neuroptomesis. So neuropraxia basically representing transient conduction block without axonal disruption and generally has an excellent prognosis. And axonoptomesis involves disruption of the axon while connective tissue structures remain partially preserved. And neuroptomesis represent a complete disruption of the nerve and usually require surgical intervention. And later, Sunderland then expanded into a five-grade classification, allowing for a more precise characterization of injury severity. And for Southern and Sunderland, we have grade 1 up to grade 5. And we can appreciate, for example, neuropraxia for grade 1, the injuries, focal segmental demyelination, spontaneous recovery, yes, and nerve conduction study, partial or complete conduction block, proximally preserved conduction block distally, even after 2 weeks. And you can even go ahead into an EMG. So this was for the Sunderland. And these classifications, they remain clinically important because they help us to determine which patients may recover spontaneously, as we see with grade 1, and also which patients may recover, like may require reconstruction. As we see, like in grade 4, there's no spontaneous recovery, but surgical intervention is necessary. Now, going into the global burden of peripheral nerve surgery, globally, peripheral nerve injuries, they represent a significant but often overlooked cause of disability. So recent burden of diseases analysis, they estimate millions of new cases annually, and the majority occur in young adults, particularly the males. And these demographic patterns, it is unsurprising because young men are more likely to engage inactivities that are associated with trauma, including transportation, construction, mining, military service, and industrial work. And importantly, the burden extends just beyond mortality because most patients, they survive their injuries. But however, the survival then often comes with long-term disability, chronic pain, reduced productivity, and significant healthcare cost. And thus, peripheral nerve injuries, they contribute substantially to years lived with disability. According to a study, it was shown that in 2020, we can see that the majority of the cause of peripheral nerve surgeries globally is falls, followed by exposure to mechanical forces. You can even see the age gaps, and the least cause really is self-harm, but the main important causes being falls and exposure to mechanical forces, even transport injuries, as we will see in Africa. And looking into the age group, um, um, again, falls it's a big thing across across a dynamic age range and exposure to mechanical forces and a little bit of transport injuries. Now, why Africa faces a unique burden? So Africa faces a unique burden because Africa possesses a unique combination of risk factors that increase the vulnerability to peripheral nerve injuries. The first is rapid urbanization. The second being increased motorization. The third being occupational exposure through mining, agriculture, manufacturing, and construction. And at the same time, healthcare infrastructure has not expanded at the same time, at the same pace. So many countries they have experienced such dramatic growth in motorcycle transportation without corresponding to the improvements in road safety, trauma systems, or specialist surgical capacity. So consequently, the incidence of severe trauma has risen while the capacity to manage complex nerve injuries remains very limited. So in Africa, there is this mismatch forms. So this mismatch, it tends to form the foundation of the challenge that we collectively face here in Africa. For the epidemiology, one of the greatest difficulties in discussing epidemiology in Africa is the absence of reliable continental data. You know, unlike stroke or cancer, peripheral nerve injuries are rarely captured within national registries. I did a small research into Zambia, into Botswana, and even into Lesotho. The national registries for peripheral nerve injuries is less than 1%. So that's how unreliable we are now when it comes to continental data. So the most available evidence comes from single centers, single center studies in countries such as Nigeria, South Africa, Egypt, Morocco, and Ethiopia. And despite this limited data, there are still several consistent patterns that continue to emerge. Like the majority of the patient are still young males, and upper limb injuries they still predominate, and trauma remains the leading cause. And even road traffic accidents are the dominant mechanism in Africa. And the true burden is likely substantially higher than reported because many patients never even reach tertiary referral centers. And that's the biggest challenge that we even have in Africa. And even for the epidemiologists, it's even difficult to comment on the epidemiology because the data is not even there because of the intense lack of resources in the continent. And just to reiterate on the mechanism of injuries, when examining the causes of peripheral nerve injuries in Africa, road traffic trauma consistently emerges as the leading mechanism. Motor, there's also motorcycle accidents. They also deserve a particular attention. And the biomechanics of motorcycle crashes frequently produce things like traction injuries, avulsions, and severe brachial plexus damage. Even industrial injuries are very significant, especially in rapidly expanding economies, because now Africa is on its stage of industrialization. So there tends to be this lot of industrial injuries. The same happens to mining, agriculture, and factories. They also contribute to complex lacerations and crush injuries. Even gunshot wounds, they remain important in the regions affected by interpersonal violence or conflict, because there are some areas in the continent that there are still conflicts, and it's even more common in people who are in the armed forces or in the police departments. And finally, we should not just overlook iatrogenic injuries, which, although they are less common, but they remain preventable causes of nerve dysfunction. So the African brachial plexus problem is that if there is one injury that best illustrates the burden of peripheral nerve trauma, it is the brachial plexus injury. And that is to say, the brachial plexus is among the most complex structures in the human body. So, injury can produce complete paralysis of the upper limb, and patients may lose shoulder stability, elbow flexion, hand function, and sensation simultaneously. So, what makes brachial plexus injury particularly devastating is that it typically affects young people, otherwise healthy individuals who are mostly breadwinners. Um, an example, a 25-year-old motorcycle rider, they can survive a crash yet remain permanently disabled for decades. So, in many respects, a severe brachial plexus injury can be functionally equivalent to a limb loss. And even on a study on in Ethiopia, it has shown that the Ethiopian experience demonstrated a road traffic accident as the dominant cause of brachial plexus problems, with severe injuries requiring complex reconstruction. So the socio-economic consequences of this is that when discussing the outcomes, we often focus on muscle strength and sensory recovery. But however, patients experience consequences extending far beyond neurological examination findings. We have things like loss of employment is very common in Africa. Many patients become dependent on family members. Educational opportunities may be interrupted. Psychological consequences include depression, anxiety, social withdrawal, and reduced self harm. So, for low income households, a single disabling injury can push an entire family into financial hardship and just push them completely into poverty. Therefore, it is imperative that successful treatment should be measured not only by motor recovery, but also by restoration of social participation and economic independence. And this also should shape policies across Africa. And the diagnostics challenges that Africa face is that the diagnostic pathway for peripheral nerve injuries, it differs dramatically between high income and low income resource settings. So you find that in many tertiary centers worldwide, patients may undergo MRI neurography, nerve ultrasound, electromyography, nerve conduction studies, and even intraoperative monitoring. But then, in contrast, when you compare to Africa, many African centers, they lack some or all of these resources. And as a result, clinicians will then frequently depend on careful history taking and meticulous neurological examination. And this places a premium on clinical skills. But one could argue that African surgeons often become exceptionally skilled clinical diagnosticians because they cannot always rely on advanced technology. So we really do lack this. And we know that clinical examination, of course, is the cornerstone of diagnosis, but things like electromyography, MRI, neurography, they make it very easier for diagnosis in peripheral nerve injuries. And these are examples of those equipments. So if I were asked to identify the single greatest challenge in peripheral nerve surgery across Africa, my answer would not be lack of surgical skill. It will be delayed presentation. And why delayed presentation is because many patients first present to local clinics, traditional healers, orthopedic services, or general hospitals before eventually reaching a specialist. And even some travel hundreds of kilometers just to access a neurosurgical care. And others simply cannot even afford transportation. So you find that by the time many patients arrive, the ideal window for reconstruction has narrowed considerably. And this delay fundamentally influences the outcome. So this is the major challenge in Africa, delayed presentation because of such issues. And the biology of delay, just to go through it, is that we all know that every peripheral nerve surgeon should remember that time is nerve. Just like other neurosurgeons, they will say time is brain. So following injury, the Valerian degeneration begins almost immediately. So the axons degenerate distal to the lesion, motor end plates, they gradually disappear. Then denervation of the muscles undergo fibrosis and atrophy. And the longer denervation persists, the lower the probability of meaningful functional recovery. And this biological reality, it explains why delayed referral is so harmful. And that is why on the previous slide, I say that delayed referral is the biggest challenge also here in Africa. And the problem is not merely logistical, it is also physiological. So that is a really big issue here. And there's also workforce challenges. Um, there was a recent study that said Africa contributes 1% of neurosurgeons worldwide. So now you can imagine that how many neurosurgeons are in Africa and how many attend to patients. So there's a vast shortage of neurosurgeons, of hand surgeons, plastic surgeons, peripheral nerve specialists, physiotherapists, occupational therapists. And a lack of this workforce makes it difficult to even attend to such cases. Also, infrastructure. Africa, we lack operating microscope, nerve stimulators, EMG facilities, MRI neurography, and these are essential equipments that can help in the diagnosis and planning and treatment of the patients, but they are not even there. So even treatment of patients and diagnosis, it becomes very difficult because infrastructure on its own, it's a problem and it leads to just bad outcomes. And the principles of surgical reconstruction is that we just want to restore the function, we want to prevent muscle atrophy, we want to relieve pain, and ultimately improve the quality of life. And that is why surgical timing remains one of the strongest predictors of the outcome. And here it's a picture of median nerve neurolysis. So these are some of the things that can be done. So indications include compression, scar entrapment, and incomplete lesions. We also have direct nerve repair. It can be used when injury is sharply transected. Um, Also, tension-free approximation is possible, and the advantages very simple, single operative field, and excellent outcomes when performed early. Here's an example for nerve repair. It was an outside in microsuture. You can also do nerve grafting. It is required when the tension-free repair is impossible. So you can get a donor from the sural nerve. And here's an example of sural nerve graft harvest. You can also do nerve transfers. And this is the greatest advance in peripheral nerve reconstruction over the last 3 decades. So we can see the Oberlin transfer, which is basically from the ulnar fascicle to the biceps branch. You can even do a spinal accessory to a supraclavicular. And the benefit is just, shorter regeneration distance, faster re-innervation, and better outcomes in delayed cases. We can also do tendon transfers that are very useful when the presentation is late especially like in Africa, whereby almost all the time the presentation is very late. So you tend to want to do more of tendon transfers, um, and also useful when the muscle end plates are no longer viable. And it is highly relevant strategy in Africa, like I said, due to the same delayed presentations. And this is an example of a tendon transfer. So this is a tendon transfer technique in a male, a 35-year-old. You can see picture A, it's preoperative picture of the left index and thumb. Fingers, old flexor was cut. And on B, it was the first stage reconstruction. You can see there's scar tissue excision, placement of adequate silicone catheter underneath intact pulley system. And on figure C, we can see the second stage transfer of the FDS of the left middle and ring to the thumb and index, respectively, with tension adjustment and fixation to the distal phalanges of the thumb and index fingers. And D, you can see that post-operative with satisfied results. And that's an example of a tendon transfer. And that's why it will be a very game changer in Africa because of delayed presentations. There's also free functional muscle transfer, also represent the highest level of reconstruction. The most common, you can do gracilis transfer. It can restore elbow flexion, finger flexion, and hand function, but it requires advanced microsurgical expertise, which it will be such a very big challenge in the African setting. In emerging technologies, we have high resolution nerve ultrasound, MRI neurography, interoperative nerve mapping, AI assisted imaging, and advanced electrodiagnostics, among others. And these technologies, they can really transform diagnosis across Africa in the next decade. And there's regenerative medicine, which is an emerging field, which includes stem cell therapy, Schwann cell transplantation, bioengineered nerve conduits, growth factor delivery systems, tissue engineered grafts. Even though it just remains mostly investigational, but it really just holds up promises for future practice. So building capacity in Africa, I recommend that we establish regional nerve centers. We create microsurgical training. Currently, there's one in Rwanda. Um, I forgot the name of the center, but there's currently one in Rwanda. And create continental registries, strengthen rehabilitation services, because again, this is a bigger challenge in Africa, a lack of rehabilitation centers. And also develop a multidisciplinary teams. Because you find that in Africa, maybe you might have neurosurgeons, but then you don't have specialized nurses who can take care of patients of peripheral nerve injuries or of trauma or of stroke and things like that. And also promote collaborative research within Africa and even the Western countries. And the research priorities for Africa, we urgently need population level epidemiological studies, national registries, outcome studies, cost effective analysis, and prospective multi center collaboration. Because without data, advocacy remains difficult. And we know that currently now data is a bigger challenge in Africa, and that's why it's also a bit difficult to advocate for anything on peripherals neurosurgery, because how do you even convince the president? How do you even convince the Minister of Health if you can't even present tangible, substantial data to them? So the take-home message is simply that peripheral nerve injuries are a major but under-recognized cause of disability in Africa. Trauma, especially road traffic accidents, remains the dominant cause in Africa, with young males or young entrepreneurs or um, young breadwinners being the most affected. And delayed referral is the greatest obstacle to successful reconstruction. Nerve transfers, they have revolutionized modern management. And currently in Africa, tendon transfer is the best because of delayed presentation. Rehabilitation is also very important. And Africa, it really does require investment in training, infrastructure, and research to improve outcomes. And I've had the privilege of talking to a couple of ministers around Africa, even some presidents, and they are open and are willing to let investors to come and set up hospitals, specialist centers, educational centers to tackle such issues. And with that said, that's the end of my presentation. Thank you.
Thank you very much, Doctor, for excellent lecture. We are starting the discussion. Start with Dr. Gabrielian.
Yeah, thank you. Thank you, Dr. Turnwell, for this great presentation. It was really interesting to see it. And you talk a lot about brachial plexus trauma. I think that's a very big problem because it also carry significant economic consequences, predominantly affect the active population. And my question is, are brachial plexus neuritizations performed routinely in Africa, or are they like isolated cases limited to one or two centers in this region? Maybe you have some data about this.
Okay, thank you, Doc, for that question. So in Africa, yes, brachial plexus surgeries, they're limited to specialized centers. This, I think there's a center in Rwanda and even in South Africa and in Zambia. So they're very limited.
I think there is a problem with, logistics here.
Yes, there's a
Okay,
problem with
thank you.
logistics, and even the cost of the surgeries is just too much because you find that most of the insurances, they don't cover most surgeries, and now it becomes a very huge burden to families, and they just decide to just stay because also the government sometimes is not really too helpful.
It's a pity. Thank you. Thank you for your answer.
You're welcome.
So the next doctor, Dr. Jose Tank, any question or comment?
Yes, thank you, Dr. Evelyn, for the opportunity. Thank you, Dr. Turnwell, for your great presentation. It seems that Indonesia is quite the same with Africa in facing the challenge of these peripheral nerve injuries. But may I know that what have neurosurgeons or fellow neurosurgeons in Africa done to advocate, or maybe uh, have you ever promote these peripheral nerve surgeries in your country so that patients won't be late for coming to your service, or anything that makes us achieve better outcome in this surgery? Thank you.
Yeah, okay, thank you. Um, this is actually an interesting question. So, so currently, what they're trying to do, um, they're trying to expand neurosurgical training programs. And one of the most significant achievements have been the expansion of neurosurgical training across the continent through organizations like World Federation of Neurosurgical Societies, even the College of Surgeons of East Central Africa, COSEXCA, and even the West African College of Surgeons. So these programs, they have tried to increase the number of locally trained neurosurgeons and reduce the reliance on overseas training. Even the creation of regional training hubs. So many African neurosurgeons have been advocating and helping to establish regional training centers where expertise can be concentrated and shared. Example include the WFNS Rabat Training Center in Morocco. There's also the COSEXCA accredited neurosurgical training program in East, Central, and Southern Africa. So these are some of the emerging neurosurgical centers. And as for advocacy for peripheral nerve surgery, I know that the WFNS Peripheral Nerve Surgery Committee has actively advocated through international courses, even cadaver laboratories, workshops, and educational programs. And the committee has even went to argue that peripheral nerve surgery should be part of routine neurosurgical training because it directly addresses disability and loss of function. So really, WFNS has been a powerhouse behind this. But even building international collaboration, there has been collaborations that has been facilitated. There have been fellowship opportunities, visiting professorships, even skills transfer. And most neurosurgeons have been advocating for neurosurgeons to take a subspecialty of peripheral because most of the time here in Africa, we tend to only want to specialize in stroke or spine, and we just feel like peripheral nerve, is not really a big thing. So they really, yeah. So a lot of work is being done. Advocacy is being done. Yeah. Thank you.
The next, Doctora Núñez, any comments or question?
Yes, thank you, Dr. Turnwell. Congratulations on your excellent presentation. I found it very interesting that delayed referral remains one of the biggest challenges in Africa. Your emphasis on early surgical intervention, nerve transfers, and rehabilitation as key factors for improving patient outcomes was very valuable. Thank you.
Thank you. You're welcome.
And the next, Dr. Tatiana. Any question or comment?
Thank you for your presentation. Thank you. I have a question about the surgery will be effective and how much time patient has before surgery when surgery will be effective.
I'm sorry, Dr. Tatiana. I think I lost you when you started. Can you kindly repeat that?
My question about post-injury time point. How much time patient has before surgery when surgery is effective after trauma?
Like you're asking, like how much time does the patient have before surgery in the African setting?
Yeah. Yes.
Okay, I think it really does take a bit of a time, but the ideal window is I would say 3 to 6 months after injury. I think it's also is considered the golden period for nerve reconstruction because the motor end plates they remain viable and re-innervation can still produce meaningful functional recovery. So patients undergoing surgery within this period consistently achieve better outcomes than those treated later. Even so that's the ideal window, 3 to 6 months. But even up to 9 to 12 months, it's acceptable because some patients, particularly with partial plexus injuries, they can still benefit from nerve transfers and grafting performed between 6 to 12 months after injury, and the outcome becomes progressively less predictable as the delay increases. And beyond 12 months, what I've seen in Africa is that the likelihood of successful reconstruction decreases significantly because of the irreversible muscle atrophy. So at this stage, that's where they usually consider tendon transfer, even though there's really no statistics or any research on that, and things like free functional muscle transfer. But in general, like when surgery should be earlier, I think certain injuries they require agent or delay, early exploration. For example, if you have like an open nerve laceration, sharp transections, even root avulsions. So this they may be operated on within days or weeks rather than waiting several months. But then again, there's an issue in the African context because there's an issue of the the policy of the hospitals and even the insurances, because here, if you can't afford it, if your insurance can't afford it, then we're not going ahead with it. That's just how it is, unfortunately. So the African reality is just that in many African setting, patients frequently present 6 to 18 months after the injury because of the same delayed referral pathways, the long distances traveled, financial barriers, like I said, and even lack of awareness. And most of the patients in Africa, they would rather prefer going to traditional doctors or spiritual or religious leaders because just like medicine will be the last resort. Hence, that's why presentation is almost always late. Thank you.
Good evening, Professor Kato. Thank you for joining us.
Hi, how are you? Thank you very much for your chair. So it was wonderful talk. And I think in Africa, trauma is the most important disease, I think. So there's so many committee in ACNS or WFNS. Maybe you can join the all webinar. And also sometimes we can welcome you to the fellowship to our place or to other place in Japan. Thank you all the
Prof.
best.
I really
Congratulations.
appreciate that.
Yes.
Thank you.
Wonderful talk.
Thank you, Prof.
Okay. Move for the next lecture. Dr. Twiza Chard, you here?
Hello, can I be heard?
Yes.
All right,
Can you
thank you
share
very
your presentation, please?
Do I need to share my screen or I send the PPT to somebody? Hello?
You can share your screen.
Can you hear?
Yes, can you share your presentation, please?
I don't seem to find the part where I can share my screen on this Zoom. It says participant, raise hands, Q&A, show captions, then more. Then under more, there's no share screen.
That is not possible because you are using an older version of Zoom. You should update it.
I failed to log into my Zoom. Okay, so maybe let the third participant present, then let me try to log into the Zoom app because I was failing to do that.
Okay.
Okay.
If you find difficulty, you can mail it to us. We will play it from our side.
Okay.
Fine.
All right. Thank you.
Dr. Richmond? You all right?
Greetings to everybody. Will I be heard? Hello, can I be heard?
Yes, of
Yeah,
course.
yeah.
Okay, thank you so much. I'll go ahead and share my screen. All right, can my screen be seen?
Yes.
Okay, thank you very much. I would like to thank everybody for the opportunity that I got to I have right now to present about this topic. My topic might not be totally scientific, but I wanted to share about something that I thought would be quite useful for students that probably are thinking about the future and thinking about the career path that they would like to take. So, as myself, an international student who is originally from Cote d'Ivoire, and which is one of the countries in West Africa, I wanted to show something that I myself have more experiences about and have gone through to the maybe international student or residents that are in training right now, so that they can get some insights coming from what I've also learned. So today I'm going to talk about the pathway to neurosurgery in China. And I will take the case of an international student, since myself I've gone through that pathway. So we'll talk about the overall pathway. I'm going to go in details about the training stages as for an international student who would like to learn neurosurgery in China, and also the key steps that could help him to get an outstanding training in China and in the institutions that are recognized for this training, and also the future plans, the planning for the future. So this is how I'm going to go. So the basic pathway for an international student who just graduated from
Your
high
slides
school.
are not moving.
They're not moving?
No, please make it full screen. Can you make it full screen, please?
Okay, let me try to. How about now?
No, we are seeing it the same.
Still the same.
It's not full screen. Can you just click on the symbol next to that? Next symbol. Down.
This one?
Next one. Yeah, that one.
Okay.
No, it doesn't.
Yeah, it's
Doesn't become full screen.
let me see.
You can also try a hotkey F5 on your keyboard.
Okay. How about now?
No. If you click on click share, you will see two windows.
Okay.
One is the full PowerPoint and another is the thing you are seeing now. You click on the full screen. Make
Let
it
me
full
end.
screen. Yeah, okay. Now make your PowerPoint full screen and then you click share.
Oh, okay. Sorry about that.
Did you click?
Okay. How about now?
Waiting. Yeah, now better. Perfect.
Is it moving now?
Yes, please go ahead.
Okay. Thank you so much. So I was saying that I will go over through this content, these four contents. So the overall pathway, the training stages, as I've in the undergraduate, postgrad, and also the specialization training. And also I will talk about the different steps that are needed to have a very outstanding training, as well as thinking about the future when it comes to subspecialty training too. So when talking about the total pathway, this pathway that I've just displayed here is mainly when an international student is graduated from high school and coming to China, thinking about studying medical school, and then maybe later thinking about doing some neurosurgery training. So we have some basic undergraduate education, usually 5 to 6 years, depending on the language you are learning. So 5 years if you're learning in Chinese, and 6 years if you're learning in 5 years if you're learning in English, and 6 years if you're learning in Chinese, as you have to take 1 year of language and then do the basic medical and clinical skill training during the following 5 years. And then for the postgraduate specialization training, you have to do your master's, and then if you intend to do your PhD, you can go ahead and do your PhD. But usually, the postgraduate specialization is combined with the residency training. So you usually our master's is 3 years, and then you go ahead and do the residency training, which is equally 3 years. And then you go ahead and do the specialty rotation during your residency and try to focus on more specific training for either vascular or functional or oncological training, neurosurgery, and then take out the examinations. So all of these steps are the different pathway, the different stages that you have to take, and then try to get your specialty test, or you go ahead and do your licensing examination. So these are the training stages. So you have to go through your undergraduate. So you have to do some basic medicine and also neuroscience training during your undergrad. You will do some clinical training during your undergrad. I think these stages are all done in most medical schools all over the world. And after that, then you have to try to think about your master's or your residency training. And for your master's and your residency training, as you can see here, I mentioned that you need to have a certain, to achieve a certain GPA that is required for you to enter into the training of neurosurgery. So this is very different across different institutions in China, but usually institutions that are accredited to give the training, the neurosurgical training in China over here, they are very strict about the GPA, because not all institutions are recognized to give the training for neurosurgery. Most of them are recognized to give training about surgery, but for neurosurgery, it's quite different, and it's quite very strict. So we have a very high GPA that is required, and also we have some exams that you need to take after your graduation, and you need to have sufficient clinical practice in the neurosurgical department, as they look over this criteria very much, because take it they take it as a first exposure that you get for the neurosurgery department, and from there on, they try to judge about your awareness of what the field demands. And just beside here, I just put this eligibility criteria, because usually when you are planning on going for a master's, you go through some process. So you have to go through an application. You also have to go through an examination. You also have to go through an interview. So those three processes can be done if you haven't met these different criteria. Over here, you can see this HSK, which is the Chinese proficiency language test. And this test is very critical. It's very important, because they expect you to be able to communicate with the patients. They expect you to be able to communicate with your mentors. So some of the mentors can communicate with you in English, but not all of them are able to do so. Hospital working, you'll be in the hospital doing a lot of communications with the staff, the nurses, and other stuff. So this HSK4 is very, very, very important when you are planning to to do your neurosurgical training. And even as of now, they are trying to lift this the bar a little bit higher, so they're trying to put it at the next level, which is HSK 5. So as international students, when you are trying to go do your neurosurgical training, you will meet a lot of challenges. I try to mention some of them over here that most of us meet when we are trying to do the training here in China. Usually the information, when I talk about career information, usually institutions over here in China have different mode of actions when it comes to um, getting the international student or enrolling international students. So most institutions try to make it very available online so that you can access them. But the details of how they accept students, a lot of limited access to along the training is very hard because there's a lot of competition. You have competition with international graduates. You have competition with the Chinese students too. So there's a lot of competition.
I cannot hear you, Richmond.
But degree accreditation, this depends on the country. We usually don't recommend do some more years of rotations because yeah, here is very to get some jobs same as or care centers. Excuse me.
There was a delay in connection. Please go ahead.
How about now? Is it okay?
Okay, now it's back.
Okay, thank you so much. Hope you can see my screen. You can still see the screen.
Yes.
All right. Yeah, so as I was speaking, I was talking about the competitiveness of employment. So beside competitiveness of employment, this can lead to also some academic pressure that will also lead to some disturbance of on the mental state, and sometimes even some problems mentally. But usually, international students um, are very organized in communities. So I think for this part is quite okay. And now, when it comes to the master's program, usually in the hospitals is 3 years. The duration is 3 years. You can access them either in Chinese or in English, depending on the schools. Most schools that give the training for neurosurgery have the options of Chinese or English. I'll put an estimation of the price here for a year, but it varies depending on the institution, and you usually have to do the application and the exams earlier, so as early as possible, so that you can get your admission in end of July. But some schools also extend when it's necessary. So here are some application details that you materials that you can have to get ready. But usually the most important is the study plans and the recommendation letter, yeah, and also your CV, because the professors or the supervisors want to see that you previously been involved in your surgery, that you know what you are getting into. So your study plan is very critical, and your CV is also very critical. So when it comes to the residency training, residency training here is very systematized, so it's very well organized, where we go through these 3 stages to build your surgical competencies. And we have the basic rotating stages where you have to rotate in um, uh, many departments that are related to neurosurgery. I think this is basically the same in other countries, just that over here, sometimes you may be asked to rotate in some departments that are related to general surgeries. And also here you can see the neurosurgery professional rotation stage where you go across different subspecialties. I don't know for other countries, but over here they make you um, go to those different subspecialties, and you also have to go to some spine department, some functional department, or oncological department, and just to make sure you get the necessary competencies that are required for neurosurgery in general. So this is for residency training. This is very basic. This rotations stages is very important. You have to go to all of this department, and then after that, when you go to the subspecialty of neurosurgery, now you have to go very intensive training for those different subspecialty in neurosurgery, and then and then at the end of that, you will go through some assessment and graduation stages. Usually the assessment stages are very the practical stages are very easy, as you've already gone through all this training during your time in those subspecialties. But the theoretical stage is what is the most complicated, and then getting the certification also might take some time, and sometimes you have to qualify for independent practice and further specialization if you want to go for further specialization. And when it comes to the rotation, just like I mentioned, these are the 5 subspecialties where they usually make you rotate: vascular, oncology, spine, functional, and interventional department. So you rotate in all these departments. I think for some other institutions, they sometimes add neurotrauma, but in here, when they send you to vascular also incorporate trauma. So usually you do both at the same place, at the same department. And these are some institutions of reference that I just listed here. These are institutions that have a very well-established neurosurgical training program. So we have this Beijing Neurosurgery Institute. We have Xianwu Hospital, which is also in Beijing, and we have the Zhejiang Hospital University, the affiliated hospital for Zhejiang University. And also my hospital is also very experienced when it comes to training international students, as they've done it for many years. They've even been one of the earlier institution to be giving training to international students. Yeah, just like I mentioned, my hospital has been one of the earliest institutions that has been giving training for international students. It's a very comprehensive training that they give over here, not only for neurosurgery, but for also other specialties. And when it comes to qualification and for the career planning, for the career progression, this is what you have to go through. So you have to do the national licensing examination after 1 year of rotation in the hospital, and you have to do the standardized residency training and assessment certification. So usually these are at the end of each rotation that you do in each department, and then at the end of the whole rotation also plan, you also have to take an assessment to certify that you you've acquired the required knowledge after going through this rotation. So you have to pass this certification before you are eligible to end your residency training. You also have to do some continuous educations. You also have to do some specialty certification. That depends. That's if you really are interested in vascular neurosurgery, or if you're interested in functional neurosurgery, if you're interested on neuro-oncology. So you do some specialty certifications too. And when it comes to the career development and stage, you can, this is the path like for international students. So you have to do the residency, and after residency you become a resident, and then when you get this title, you have to go ahead and work in the hospital for some years, do some research, and after research, after some achievements and some years of experience, you have to take an exam to become an attending. And what follows next is for you to become a chief physician. Though for international students, this is very complicated. It's very hard for you to move from resident to attending in the Chinese hospital, but it's still possible as long as you work very hard and you have a clear path that you've already traced for the future. But most of this depends on clinical research and publication. So all of these stages will depend on the achievement that you have in the literature, journals, and also in the research in your institutions where you are training. So I've mentioned here some important steps for you to be very successful here in China. As for the bachelor degree, for the undergraduate degree, it's mostly your GPA and your exposure in the neurosurgical in the neurosurgical department. For your master's degree, it's mostly how successful you are, how efficient you are during your clinical training and also during your research. So I mentioned here research publications, I mentioned clinical experience, because these are very important. And I think one of the very underrated factor here is the language proficiency, which I think is very, very important. You need to be very proficient in Chinese, because you do a lot of communications with the patients, a lot of communication with the staff. Some of them are not that fluent in English, and it's true that you can make it very easily in English, but the most important, as for you, for the development of your communication skill with your patients, will be the language proficiency, the Chinese language, and the rest is also as important as the others. But I think for these first four, they are the most critical ones. And when it comes to the research expectations, depending on the institution, this expectation varies. Usually for research time, you have to do approximately 2 years at least, and you have to do certain numbers of publications. I didn't mention the numbers here because different institutions have different requirements. For my institutions, before you graduate for your master's, you have to publish one article. You have to publish one article, and at least one article. That's for your master's. And if you're planning on going to a PhD, then you and in higher journals. So these are the different details. And what people reported after the graduations, which them to be very very successful, was about 30 months of research time. So here I mentioned about 24 months. So, but for the people who have made it, who have done this whole process before, they mentioned about 30 months of research time. And for the publications, it also varies based on the institutions. But 5 publications is what is the recommended one if you're planning to go into a PhD degree and continue your training. So I'll talk about more of the career planning. Here, China has been training international students for a very, very long time. They have a lot of partnerships with different countries, and they have very good institutions for training students that want to learn neurosurgery, and sometimes they even offer you opportunities to go abroad and continue your training. So I think this is a very good destination for people who really want to get the training. And I would like to come back again and mention about this. Among all of these points, I think the most important that I would like to stress again will be the language and also the dedication to research. Yeah. And here I will just end my presentation. Thank you very much for giving me the time to present.
Thank you very much, Dr. Richmond, for very informative lecture, and congratulations. Your journey across border is truly inspiring. I wish you continued success in your neurosurgical career.
You're right.
Any question for the discussion?
Yes, may I ask one question?
Yes.
Thank you for the excellent presentation. I'm really impressed by the progress in medicine and neurosurgery in particular has made in China. And in our country, we have 2-year residency and also have a rotation between different deep neurosurgical specialties. And I think my question is simple. What pathway does a neurosurgeon from another country need to go through in order to be able to practice neurosurgery in China?
Okay. I think that's a very good question. Thank you very much, Dr. Yontin. For the pathway will be first have a residency accreditation. That's the first thing. And the second thing will be taking the medical licensing examination. So those two are the most important. So the residency accreditation and taking the medical licensing as examinations. And depending on the institutions, they may give you some requirements about the language, like I mentioned here, about the HSK examination. But usually the residency accreditation plus taking the Chinese medical licensing examination will be enough.
Thank you. Thank you for answering.
Thank you.
Any other comments? Dr. Alexander, please.
Yes, thank you, Dr. Evelyn. Thank you, Dr. Richmond, for your wonderful presentation. When I saw that presentation, there are some specialties that they are different in my country. I saw that you have oncology, spine, vascular, and neurointervention, and one is functional. But I wonder if whether in China, if you are pursuing career in vascular, it means that does it means that you just pursue the surgical vascular but not endovascular, or how did our fellows in China differentiate the intervention part and the vascular part? And is there any pediatrics division too, or trauma division in China? And is there any particular pathway to achieve that subspecialty there? Thank you.
Thank you so much, Dr. Alexander. That's a very good question. I will start with the first one. So in China here, when you do the the residency, you rotate in all of these departments that you mentioned, but after that you can go into subspecialty training. So the neurointervention and vascular are separate. They are separated when you go into subspecialty training. So they are separated. So when you do vascular, you do mostly surgical interventions like craniotomies and other stuff. But when you do neuro interventions, you do those that are related to neuro interventions procedures. So those are separated. Those are separated. So that's mainly about subspecialty training. So you have to do your subspecialty training to be able to go into procedures that are neurointerventional and procedures that are going to be done through craniotomies. And second thing that you mentioned is about if there were pediatric neurosurgery. Yes, there's pediatric neurosurgery. I think I omitted that in the presentation, but it's also one of the subspecialty training. And for trauma usually comes with cerebrovascular. Yeah, so for trauma, usually they come with cerebrovascular. So when you do your cerebrovascular subspecialty training, you also do a trauma training. Usually they are together. And for the last questions, if you could remind me again, Dr. Alexander.
No, I think it's accomplished,
Okay.
Doctor.
Okay,
Thank
Dr.
you so much.
Núñez, Dr. Janet, do you have any question?
Yes, I have a question. Well, first, thank you, Dr. Richmond. Congratulations on your excellent presentation. My question is, in your opinion, what is the biggest challenge that international residents face during neurosurgical training in China?
In my opinion, there would be the biggest challenge will be the language. I think the biggest challenge will be the language because a lot of students are very smart, but when they come to the country, they struggle with the language because over here they give a very, 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 very importance to communication skills. I think that's one of the challenges that most international students comes here who are very smart. They have achieved a lot during the undergrad. They achieved a lot maybe during the residency training, but when they come over here, they struggle with the language because the language you can be a very smart student, you can be very skillful, but when you get to the hospital and you are unable to communicate even with your supervisor, or you're unable to communicate with the patients, it becomes very frustrating. And sometimes students even they change the mind because of this specific reason. So the language is the biggest challenge most students face here, in my opinion.
Thank you.
Thank you so much, Dr. Janet.
Okay, thank you very much for the time. I think continue with the next lecture. Dr.
I'm sorry,
Cebolenkhosi.
can I have a question?
Okay, please.
I'm sorry.
Go ahead. No, go ahead.
Dr. Richmond, thank you for your presentation. I know that we need to spend a lot of time in the hospital, and it's very interesting. Do you have any operative or clinical deadlines per day? What is actually your load?
Oh, okay. So usually you when you are an international students who is working in the hospital in a certain department, you are assigned with a specific doctor who has the duty to oversee everything that you do. So usually whatever that doctor does, you are supposed to assist. So the doctor will give you directives and what to do. And usually you have to assist in the ward and you have to assist in the OR too. But there's no specific or standard, let's say, requirements that is given for a student. So it will depend on the doctor that oversees you. So I don't know if I've answered that question. Dr. Tatiana, did I answer your question? Okay.
I think there's a problem with connection.
She's frozen. Okay. Continue with Dr. Cebolenkhosi with your lecture, please.
Good afternoon. I do hope I am quite audible. All right. So my names are Cebolenkhosi Mndzebele. I am a medical student from Lusaka Apex Medical University. So may you kindly allow me to share my slides. Okay. All right. Okay, so we're going to we're going to start right here. So my presentation for today is going to be on the blood supply of the brain, arterial supply to be specific, which is mostly going to be about the cycle of Willis. So as you know, the cycle of Willis is the main blood supply, or rather main arterial supply of the, and the history of this lecture is basically from Thomas Willis, who was the one who actually came up with the name cycle of Willis, or rather we appreciate the cycle of Willis today because of the great physician Thomas Willis. So I'll just get right started by talking about the anatomical position of the cycle of Willis. So the cycle of Willis is anatomically positioned at the base of the brain, which is specifically within the interpendicular system of the subarachnoid space. I do hope that we can quite appreciate the photos. Okay. All right, so I do hope we can appreciate the images. May I kindly get feedback if we are able to see the photos?
Yes, we see it.
Oh, all right, thank you so much. So as we can see that the cycle of Willis is this nice circle, or rather, yes, this nice circle, which is right at the base of the brain. Specific position is the interpendicular system of the subarachnoid space. And of course, if you're to view properly or zoom in into the brain, right at the base of the brain, you're going to see that there is going to you're going to appreciate very well the optic chiasm as well as the other cranial nerves, specifically the cranial nerve number 2. Okay, and then other key structures that the cycle of Willis is going to encircle are as well the infundibulum as well as the mammillary bodies. Of course, anatomy can't go without us explaining about the anatomical relations. So when we're talking about the anatomical relations mentioned, if we're to look into the image right here, we can really appreciate cranial nerve number 2. We can appreciate as well the optic chiasm, okay? And then as well as the optic tract right there, as well as the pituitary gland, okay? So this is quite a very beautiful illustration of the. So when we look into the relation, we're going to go systematically to talk about how there is the superior, the inferior, the anterior, as well as the posterior relations. So when it comes to the superior relations, so when it comes to the superior relations, the circle of Willis is going to underlie the hypothalamus as well as the floor of the third ventricle. And inferiorly, it is going to sit right above the bacilla of the optic bone, okay, as well as the sella tunica. And then anteriorly, it is going to be bordered by the longitudinal fissure, which is between the frontal lobes of the brain. And then lastly, when it comes to the posterior relation, it is going to be bordered by the pons, okay? So right here, we can actually even appreciate very well the pons as well and the cerebral peduncles, okay, of the midbrain. And then we can also truly appreciate all other structures that I mentioned. For those who have just joined us, we are talking about the circle of Willis, and we are talking about right now the anatomical relations. So I'm just going to talk about it once more and emphasize on the anatomical relations. So I did talk about the superior boundary, well, not really the superior, but rather the superior relation. We're talking about the inferior relation, the anterior relation, as well as the posterior. So when it comes to relation, it superiorly it underlies the hypothalamus as well as the floor of the third ventricle, while inferiorly it is going to be above the occipital bone, also known as the clevus, as well as the sella tunica. And then anteriorly, it is going to be bordered by the longitudinal fissure between the frontal lobes of the brain, and posteriorly, it borders the pons as well as the cerebral peduncles of the midbrain. So we have talked about the anatomical relations and have tried to actually appreciate part of the structures that the circle of Willis encircles, as well as the relations of the circle of Willis. Now, let us talk about the formation of the circle of Willis. When it comes to the formation of Willis, is going to be actually formed by two systems, which is basically the vertebral system as well as the carotid system. Okay. So the vertebral system is going to be formed by what? It is going to be formed by, sorry, let me remove this right here. Okay. So when it comes to the vertebral system, here we have our two vertebral arteries. Okay. So our two vertebral arteries are going to conjoin to then form what? Are then going to conjoin to form the basilar artery. Okay. And then underneath the vertebral artery, appreciate very well the anterior spinal arteries. And then feeding into the vertebral artery is the what? Is the posterior inferior cerebellar artery, of which we're going to talk about these arteries quite a little bit in depth as we move on with this short lecture. And then, as I have talked about the two vertebral arteries, they are then going to form one bigger artery, which is known as the basilar artery. So the basilar artery, on the lateral aspects of the basilar artery, we have the pontine arteries. So these pontine arteries, as the name suggests, they are going to, of course, be the blood supply of the pons. And then when we look again, we also see the anterior inferior cerebellar artery, which is going to be the blood supply of the cerebellum. And then we also have the labyrinthine, artery, also known as the anterior auditory canal. Sorry, not auditory canal, but rather the internal auditory artery, yes. And then we also can see the superior and the superior cerebellar artery, okay. And then at the end of the basilar artery, we can see that the basilar artery then branches to give us what? To give us the posterior cerebellar, to give us the posterior cerebral, sorry, please forgive me for that. It gives us the posterior cerebral arteries. Okay, so on the left-hand side as well as on the right-hand side, we can see that we have the posterior cerebral arteries. And then right here in front, we can see these small arteries, which are known as the posteromedial central arteries. And then this is where the cycle of Willis gets to be formed. And this is the interesting part of the blood supply of the brain. From the posterior cerebral arteries, we can all appreciate very well the posterior communicating artery. So the posterior communicating artery is then going to meet the middle cerebral artery. Okay. And then again, we are going to have another artery right there, which is the anterior cerebral artery. And then the communicating artery, which is going to help to conjoin the two anterior cerebral arteries, A1, especially the A1s, okay, because there is A1 as well as A2. There is going to be the anterior communicating artery. So the anterior communicating artery is going to be the one that helps to join the two A1s. Hence the anterior communicating artery. And then we have small arteries right there, which are the anteromedial central arteries. So if we have the posteromedial central arteries, we are also going to have the anteromedial central arteries. This is the most interesting thing about the cycle of Willis. And then, of course, there is going to be the recurrent artery of Hebner. Okay. And then in the middle cerebral artery, coming back to the middle cerebral artery, it is going to continue as the what? The internal carotid artery. So this is where now we can actually appreciate both systems that I talked about earlier on. We have talked about the vertebral system as well as the carotid system. So the carotid system coming from or being derived from the internal carotid artery. And then when it comes to the vertebral system coming from the vertebral artery. So when it comes to the vertebral system, as I mentioned, we have the left as well as the right vertebral arteries, which are going to arise from the subclavian arteries. These are going to form the basilar artery. And the basilar artery, as I mentioned, is this beautiful blood vessel that is right here. So the basilar artery is then going to give us what branches? It is going to give us the posterior cerebral artery, the superior cerebral artery. Okay, so when it comes to the posterior cerebral artery, this artery is going to be important in the sense that it is going to supply the posterior aspect of the brain, which is the occipital lobe. Okay, the inferior temporal lobes as well as parts of the thalamus. And then coming to the superior cerebellar artery, this is going to supply the superior half of the cerebellum as well as part of the midbrain. And then coming to this carotid system, the carotid system is the one that actually helps in the supply of the anterior aspect of the brain. So what are the arteries or the branches of this internal carotid artery? These include the anterior cerebral artery, the middle cerebral artery, as well as the posterior communicating artery. So for the anterior cerebral artery, it is going to form the anterolateral portion of the circle of Willis. And just like we said, it is going to be connected by the anterior communicating artery, of which part of the branches of this anterior communicating artery is the anteromedial central arteries. And then also we have the middle cerebral artery. Okay, and that, however, this one, it's important to note that it does not contribute to the circle of Willis. And then lastly, we have the posterior communicating artery, okay, which connects the internal carotid artery to the posterior circulation via the posterior cerebral artery. As I've mentioned that this is quite a very short lecture, so when it comes to the clinical aspects, this is where I'm going to give myself a little bit more time to explain, because I'd like to also share my insights of this part. So when it comes to the clinical aspects, we first talk about the stroke. Okay, so a stroke, there are two types of strokes. There is an ischemic stroke as well as a hemorrhagic stroke. So when it comes to the ischemic stroke, this ischemic stroke is going to, when it comes to imaging, okay, imaging investigations, the most commonly used imaging investigation is going to be the computed tomography, CT scan, okay, brain CT scan is going to be used for, is going to be used when it comes to the investigation of an ischemic stroke, not only though an ischemic stroke, but also a hemorrhagic stroke. But of course, there are other imaging modalities such as the magnetic resonance imaging scan, okay, the MRI. When it comes to the CT scan, what is it that we are going to really appreciate for the ischemic stroke? What we are going to see is that there is going to be a hypodense lesion. Okay, so in these imagings, we can see that there is a hypodense lesion in the MCA. So this is right MC, right sorry, it's a left MCA. Yes, okay. So this is actually as a result of a thrombus blocking part of the blood vessels in the circle of Willis. Okay, so if there's going to be a blockage of the small blood vessels in the circle of Willis, then there is going to be the manifestation of an ischemic stroke, of which, just like I mentioned, what we are going to appreciate is a hypodense lesion on the CT. So this is the normal CT. Okay, so this is a normal brain CT, while this is going to be an abnormal brain CT, of which part of the treatment options that I've actually had the privilege of seeing, okay, in Zambia is there was a procedure that the neurosurgeons tried to actually do, which was the stenting procedure, which was the removal of the emboli. Okay. And then when it comes to the hemorrhagic stroke, this one is actually due to a rupture of an aneurysm, okay, at a certain point of the circle of Willis, of which we're going to talk about more of the aneurysms. Okay, so if there is going to be an MCA stroke, what are the clinical manifestations? There is going to be contralateral weakness, okay, which is on the face as well as on the arms. And then if it's going to be an ACA, an anterior cerebral artery stroke, this is going to be manifesting as leg weakness as well as urinary incontinence. And then if it's a PCA stroke, then there's going to be contralateral homonymous heminopia as well as with macular sparing. Okay, so I'll come back to these images, getting back to them. I did explain that this image is showing us what? An MCA stroke, an ischemic stroke. Why? Because there is the hypodense lesion. While this image on this other side is showing us a hemorrhagic stroke. Why? Because there is a hyperdense lesion. So coming to another clinical aspect that must be further mentioned are the aneurysms. So for the aneurysms, we have the places where aneurysms are mostly common are going to be the anterior communicating artery. So an aneurysm is basically the ballooning of the artery, which is mostly due to the loss of collagen, okay, of the artery, hence the ballooning effect that is going to be seen. So the types of aneurysms, they are going to be berry aneurysms, which are going to mostly cause what? Subarachnoid hemorrhage if they rupture, okay, as well. And then also it is going to manifest as bitemporal hemianopia, okay, because there is going to be an effect on the optic pathway. And then in the posterior communicating artery, that is known as the posterior communicating aneurysm. So it is mostly going to be associated with cranial nerve 3 palsy. So when it comes to also some of the treatment modalities of aneurysms, there are procedures such as coiling, which can be done to prevent the rupture of these aneurysms, as well as clipping, which can also be done to actually prevent these aneurysms from rupturing. As I mentioned, that this is quite a very short lecture. This is where the lecture comes to an end. Thank you.
Thank you very much for excellent presentation, Doctor. Any question or comment, Dr. Tatiana?
I can say some comments to this presentation. Thank you for this great talk. I think it's obvious understanding of cerebral blood supply is essential for surgical planning, and not only in vascular neurosurgery, but of course in neuro-oncology as well. And there is a lot of foundational literature on the variability of cerebral blood supply. As an example, I prefer Rotten, with his great material. And I'd also like to draw attention to perforating arteries, which we frequently encounter in brain microsurgery. Unfortunately, these can be injured during retraction of brain lobes, and these vessels are very variable too. I don't have questions, but I think I'd like to suggest an interesting topic for one of the upcoming presentation. I think it's the blood supply of the spinal cord. In my opinion, is far more complex than many people assume. And I think it could be a great topic for next presentation in this committee. Thank you.
Thank you for the comment. Dr. Alexander?
Thank you, Doctor, for the great presentation. I didn't have any questions.
Dr. Janet?
Yes, thank you, Dr. Cebolenkhosi. Congratulations on your excellent presentation. Well, as neurosurgery resident, we learned the anatomy of the circle of Willis from the very beginning of our training. For example, here in Peru, are very common in our emergency, the aneurysm, especially intracranial aneurysm. I believe that a true understanding of the circle of Willis is essential for the correlation clinical finding with neuroimaging. And a part of that, thank you, Dr. Leonetti, for your recommendation.
Okay, thank you. And the last lecture, Dr. Twiza Chard. Dr. Twiza Chard, you are right with your presentation?
Yes, I'm here. Can you hear me?
Yes. Can you share your presentation, please? Okay.
Okay. So, hello everybody. I hope I can be heard. My name is Dr. Twiza Chard, and I'm a neurosurgery resident here at the second affiliated hospital of Wenjo Medical University. I am from Zambia, and I'm studying here in China. So my topic is going to be about trigeminal neuralgia. Okay. Okay. So for trigeminal neuralgia, we have 5 features that define it, which are electric shock-like pain lasting seconds and strictly on one side within trigeminal territory, then set off by something really harmless like maybe a breeze, chewing or brushing of teeth. Then you start to feel the pain. Then a normal neurological examination can also maybe prove that you do have trigeminal neuralgia, and pain-free intervals, it comes at times, then at times it doesn't come, so it depends on when it comes. So when it comes, you get to feel the pain. That's what the term neuralgia means. It's a very severe pain. Then what causes it? What causes it? So what causes trigeminal neuralgia. Before I talk about that, maybe we can talk about the epidemiology. So for my epidemiology, you see that 4 per 100,000 per year, with a mean of 63 years. It mostly has a mild female predominance, and 2 numbers worth carrying. Onset before 40 is atypical and should send you looking for a cause. And bilateral disease is only 1%, but nearly 1 in 5 of those patients has multiple sclerosis. And then what actually causes it? We have 3 categories. We have classical, secondary, and idiopathic. So for the classical trigeminal neuralgia, you see that it affects 80 to 90% of the cases. So the superior cerebellar artery compresses on the nerve at the root entry zone. Then for the secondary category, you see that an MS plaque or posterior tumor is seated and is compressing on the nerve. Then for the idiopathic, nothing is found on optimal imaging. You just feel a certain sensation. So vascular contact is present in up to half of normal autopsies, and contact alone proves nothing. So you see that its compression, and distortion of the nerve is what matters. So how the pain is generated. So at the root entry zone, central myelin becomes peripheral myelin, a few millimeters that are thin and unsupported. Chronic pulsation strips myelin from that segment, and 2 things follow. That touch the fibers begin discharging directly into pain fibers, then apoptic transmission, and the injured axon starts firing on their own in high frequency bursts. That single mechanism explains everything on this other side that says that which is why. So why a breathe causes agony? So there is touch input which is rerouted into pain pathways. Why the pain is electric rather than aching. Why there's a refractory period after each attack, and why carbamazepine, a sodium channel blocker, works. So for the clinical features, there is sudden electric seconds long trigger zones around the mouth and the nose, and it stops during sleep. Then you see that the V1 is actually rare. If we go back to the first slide here, you see that this V1 of ophthalmic nerve is actually rare, but in most cases patients have this maxillary nerve and mandibular nerve pain. So you see that for the clinical features, there is sudden electric secondary long trigger zones around the mouth and the nose, and it stops during sleep. And these patients stop eating and stop washing their faces. And if you want to see how the pain actually happens, there's this study that my professor was actually working on. We had to research on YouTube videos, or rather social media videos, of how it is presented in different patients, of which for me, I was in charge of the TikTok videos, and I got to see many patients how they're actually content creators who actually record themselves and take note of the pain each time it comes. Then for the differential diagnosis, for trigeminal neuralgia, the differential diagnosis, we have glossopharyngeal neuralgia, which is the same pain in the throat triggered by swallowing. Then we have dental disease, is the commonest misdiagnosis. And then many patients lose teeth before they decide to go to the hospital. And then persistent idiopathic facial pain, it is constant, no triggers, no response to carbamazepine, so usually do not operate on that group. Then for diagnosis and investigation, you see that for the diagnosis, it is clinical against the ICHD3 criteria, then document the division because that determines the procedure, and document the examination because it is your pre-operative baseline. Then on investigation, record the MRI with a thin sliced T2 sequence and MRA before any decompression. So I usually take pictures and videos just to save for all the surgeries that I participate in or assist in. But I just realized when I was trying to insert pictures of how the scans look, I couldn't find any video or picture on my phone. So I'm sorry I couldn't insert any evidence here to show how it looks on the MRI T2 sequence or MRA. And then one regional point, so you need to screen for HLA-B before prescribing carbamazepine. Then the medical therapy. So for carbamazepine is the first line and the only drug with a genuinely high response rate, about 69%. Then oxcarbazepine is the same active compound, better tolerated. So then we have baclofen and gabapentin, which are add-ons, and intravenous phenytoin is for the patient in crisis who cannot open their mouth. Then take note, 3/4 of these patients will eventually need a procedure, because even with the way like I was in charge of the TikTok videos in researching, I noticed that most of the patients that went for treatment, some went for what do you call that, TCM, traditional Chinese medicine. After doing those procedures, only for them to find that it was only temporary, the pain still came back. And then some patients actually had the pain and went to a chiropractor, but still the pain continued. So at the end of the day, no matter what people try, or maybe they take drugs, they end up, the best treatment rather is to have surgery. And then when and how to operate. So operate when drugs stop working or their side effects are worse than the disease, and do not let that drift for years. Then fit or healthy patients suggest decompression, which is MVD. Then frail patients suggest percutaneous. Then V1 or V2 suggests balloon, which is PBC, percutaneous balloon compression, because the corneal reflex tends to survive. Then for V3 alone, suggest radio frequency, which you can lesion 1 division selectively. Then multiple sclerosis, never a decompression because there's no vessel to move. Then for percutaneous balloon compression, this is a minimally invasive surgery. But for most of the patients, the first surgery we always do for all the patients is MVD. Unless otherwise, that's when we do percutaneous balloon compression. So for PBC, you see that it's described by Mullen and Lichter in 1983. And then the needle enters the foramen oval 2.5 to 3 centimeters lateral to the oral commissure. Then a number 4 Fogarty catheter is advanced into the Merkel's cave and inflated with contrast to about 1.4 atmospheres for a minute to 90 seconds. Then the pear shape on lateral fluoroscopy is what you look for. So it confirms that you are in the curve, and it predicts a good outcome. Then the 3 advantages are the patient is asleep throughout, it preferentially injures the large touch fibers that carry the trigger, and the corneal reflex usually survives. Then take note, you need to know that of the trigeminal decompressor response, there's bradycardia and asystole the moment you inflate, and have atropine drawn up before you start. So for this surgery, personally, I've only assisted maybe in 3 to 5 of them, and each time we had the surgery, I didn't get the chance to take pictures of the procedures, but my professor did explain to me and did give me the chance to blow the balloons and explain to me like what it does. So even for this slide, I couldn't insert the pictures. Then this is one of the surgeries that I did, and I think this is like maybe after the surgery, we had to put the rod. I'm sure here you can see like right here, right? So you have to puncture from the cheek here, and then of course it doesn't affect the teeth or anything like that. If you puncture it precisely, you will see that it will go through the foramen oval right here, but it needs precision. Okay, so these are our own reconstructions here at our hospital with the cannula in place. And I took pictures during the surgery. You need to be steady and careful during this surgery, because if you stray anteriorly, you will be in the superior orbital fissure, which can cause blindness, and never more than 8 millimeters beyond the cleval line. The third and sixth nerve are immediately beyond it. Then for MVD, which is the one that we do mostly, for MVD, which means the microvascular decompression, is the only operation that treats the cause. During surgery, a small vertical incision behind the ear and a cranectomy of about 3 centimeters, a keyhole to the cerebellopontine angle. You need to drain the CSF before you retract, and the cerebellum falls away on its own. Then also you need to preserve the superior petrosal vein if you can. Then for the MVD, the discipline is to inspect the whole nerve from brainstem to Merkel's cave rather than stopping at the first vessel you see. Then dissect the artery free, then interpose Teflon so it cannot fall back. If there is generally no vessel, do a partial sensory rhizotomy. So these are our own cases. I took pictures during surgery. So the nerve is in the cerebellopontine angle with the vessel across it. Then the vessel dissected free and lifted away. The decompressed nerve and the Teflon is placed holding the artery permanently off. That plangent is the whole operation, everything before it is exposed. So specifically for these pictures, this is when we just started the surgery, but then they haven't yet put the Teflon, so you won't see it here, but this is the blood vessel. Then we are trying to expose the trigeminal nerve. Okay, so for this one, I haven't yet studied it as much, but our professor was watching one of the YouTube videos, and he told us about the Europe doctors that used a certain patch to lift the blood vessel away from the nerve. So for us here at our hospital, we use the artificial dura patch. So unlike putting a Teflon in between, you can also put, like you see here, this is the Teflon here, but just to make sure that the blood vessel is not pressing onto the nerve, we put a string around the Teflon. We cut like a rectangle of the Teflon, then we put a string here, then we tie it to the side so that it permanently doesn't press onto the nerve. So we do not always interpose Teflon where the vessel is redundant or tedious. A plangent gets displaced and the artery simply falls back onto the nerve. In those cases, we cut a strip of artificial dura and we use it as a sling to lift the the vessel away, a transposition rather than an interposition. Nothing is left sitting on the root entry zone. So each time before we start the surgery, we always have to put the electrode leads. So for the electrode leads, because you know that trigeminal neuralgia affects one side of the face. We have the V1, V2, and V3. So we have to put the electrodes. For these are the electrodes we use. They have different colors, but the colors don't matter from what my professor told me. The colors don't matter with these electrodes. It's all about the placement, where you connect them. It's just that I didn't insert the picture of the thing where we connect them. But when you're connecting them, you need to make sure that this yellow and white lead is onto the forehead, then one above the eye, one below the eye, but it shouldn't press into the eye, only like at the bottom, at the bottom, but not, the sharp part shouldn't go towards the eye. Then the others are put above, near the ear here, then one below the mouth, the other above the mouth, then one on the chin, and the other here in the jawline. Then you see that as you are taking note of the waves, you see that these electrode leads send signals, right, to the monitor. So when it sends signals, you see that here where it says call, E5, E6 call, it's sending the waves of the mouth area. Then this part is sending the waves of, I think, the chin, and then this part is sending the waves of the forehead and the waves of the eye area. So if somebody has trigeminal neuralgia, you see that mostly the waves onto this electrode will be, they won't be straight, they'll be wavy, you know. But then as we put the Teflon, as we try to put the Teflon or move the blood vessel, the SCA, superior cerebellar artery, away from the trigeminal nerve, you see that the line becomes straight. So you see like this one, the line is straight, and this one is straight. Yeah, maybe it doesn't look very straight, but when you see, it was actually worse than this, which shows that now there's no contact between the nerve and the SCA. Then you see that the radiosurgery is the least invasive option, then 70 to 80 grade to a small target at the root entry zone. Most improve, but only about 2/3 become pain-free, and it takes 3 months to work, so never for a patient in a crisis. Then the percutaneous procedures buy fast relief at the cost of a numb face. Decompression preserves sensation and lasts longest. Then for the prognosis, not a fatal disease, but relentless. Remission shortens, doses climb, and some develop a constant background ache that predicts a worse surgical results, which shows us the 2/3 respond to carbamazepine at first, then 3/4 eventually need a procedure. And the point I would press hardest is always get the treatment earlier than you waiting for it to get worse. So these are the few questions that I prepared. If you have any questions, please feel free to let me know. Thank you.
Thank you very much, Doctor, for excellent presentation. Any question or comment, Dr. Gabriel? Oh, Dr. Turnwell, please go ahead.
Okay, thank you, Dr. Chard, for that amazing presentation. So my question is on the Teflon pad that you talked about. And immediately I saw your topic, I went to do some research before coming here. So I have a unique question to say. So for Teflon felt displacement or granuloma formation, It remains a top cause for MVD failure and long-term recurrence. So, given the high volume of revision MVDs, surgeries that are handled by major Chinese neurological institutes, are there any specific procedural variations that are preferred in China, such as maybe hanging or bridge techniques that suspend the offending artery away from the root entry without using the Teflon pads at all?
For me, I can only answer according to what we use at our hospital, because to answer your question, first of all, like the way Dr. Assi had presented, in China, it's about the doctor that has the skill in that. For example, like if you're a neurosurgeon in the neurosurgery department, you can't do all the surgeries. You have to attend certain skills in specific types of diagnosis. So for my professor, he specialized in this one, right? MVD and PBC and other types of diagnosis. So for him, the procedures that we do, it's either we do MVD or PBC. It's either we put a Teflon, or the recent one that he's been telling us to work on and to study on is using the Dura patch to just make sure that apart from putting the Teflon, at least the Dura patch lifts the blood vessel away from the SCA, right? And then for the PBC, for that one, it's why patients also use PBC is because it's a minimally invasive surgery. You don't do a craniotomy. They only put the metal, the rod through your cheek, and then it has to pass through the foramen oval. So most patients end up doing MVD because it's more precise. When we open the head, at least that one we can see it clearly, which is more accurate than using PBC. So that's the best I can answer the question according to what I am exposed to.
Okay, thank you, Doc.
Excuse me, may I have one question?
Yes, please.
Thank you for your great presentation. It was very interesting. I have some experience in this surgery, and in our center, we often make MVDs for these cases, and that's my question. Are there some cases when you consider radiosurgery as a first-line option? Maybe when patients don't want to have a craniotomy, or in some cases. Are there such cases in your center?
For me, I personally haven't done the radiosurgery before, you know, because whatever like the doctor advises to the patients, that's what we go for. So I personally haven't participated in radiosurgery.
You in your center, MVD is preferred, yeah?
Yes, it's either for trigeminal neuralgia, it's either MVD or PBC.
Okay, thank you for your answer.
Yeah.
Dr. Alexander?
Yes, thank you, Dr. Evelyn, for the opportunity. Thank you, Dr. Twiza, for your great presentation. One of the most challenging problems in doing the MVD is positioning, Doctor. May I have the tips of yours? How do you position your patient? Is it when doing the park bench? Is it the mastoid tip to be at the apex, or do you have any angle so that when we start doing the craniotomy and the burr hole, and we will be on the top of the neurovascular conflict, or any tips for that? Thank you, Doctor.
Thank you so much. So when positioning the head, because I act as either the first assistant or the second assistant. So maybe me and the other doctor will get in and position the head, right? When we put the patient onto the bed, what do you call that? I've even forgotten the name. But when we put it below the head, right, you'll find that at the end of the day, when our professor comes, he will have to maybe increase the angle. This is why he gets the drips. So he has to increase the number of drips so that the head is slightly facing to the top. The face, rather, is slightly facing to the top, and the occipital is slightly facing down, touching the drips instead. So it's more of where he will sit, because he is the one who does the surgery. For us, the first and the second assistant, our job is only to assist, but the one who does the main surgery is always the head of department. So for us, even when they're doing the burr holes, that's where maybe you find that the first and second assistant, we have to hold the head steadily so that the drills properly. So I don't know, maybe if I've answered your question.
May I ask one more question, please?
Yes.
I don't know how to say that. Did you had a venous compression, or you saw only arterial compression of trigeminal nerve?
I think I've only seen the arterial compression.
Because there are some cases with a venous compression as an isolated cause of neuralgia, and it is very interesting because the clinical presentation can be different, very different, and it is interesting to make criteria for this diagnosis. I saw, I think, 2 or 3 cases, and that was very interesting, my experience.
Yes, that's true. That's true.
I think in the audience, Dr. Shafar, do you have any question?
Yes, thank you for this opportunity, and thank you, Dr. Chard, for your wonderful, brilliant presentation. I would like you to maybe give me an insight. Are there situations where you've gone intraoperatively and found that this patient has trigeminal neuralgia? Okay, you're going for microvascular dissection, MVD. However, you don't find any compression from my vessel. So the nerve is there, there is pain, but there is no culprit vessel compressing it. Then what would you do in that situation? Then what are the long-term, in case you do an MVD and there's no remission of symptoms, are there any other adjuncts that you employ? Thank you.
Thank you so much, Dr. Shafa. Well, I think for every doctor, before you do a procedure, you need to first confirm. If I've understood your question, from my understanding, you're saying like maybe we open and then only to find that there's no compression. I think that will also put everyone present in trouble or liable for misdiagnosing, because when you're first admitted at the hospital, they first monitor your pains. After the monitor, you need to do the scans. The scans will show where the compression is. It's very minimal. To know that you have trigeminal neuralgia through the scans, you need to practice to read a lot of scans. It's very minimal. So you need to look at a lot of scans, and then after that, also when we connect the electrodes, you'll find that the electrodes will show the trigeminal neuralgia. Let me just where's the picture? Let me just look for the picture. These electrodes too show that you do have the trigeminal neuralgia. Maybe the waves might not be much, but the waves will be there, and they're always there. So I don't think there's a point where you have to misdiagnose a patient. And even though it's not like when you enter, it's a very physical thing that you see that, oh, the nerve and the blood vessel, they show mostly like they're touching each other. No, at times it even looks like they are not, because the moment you do the craniotomy, you see that the moment you're sucking the CSF, the moment you keep on sucking out the CSF, maybe that's also causing the blood vessel and the nerve to be separated a little, but there's no point where you can just mismatch before you open a patient, in my opinion. So even after we put the Teflon, to just make sure, there's this procedure now where we are using the Dura patch to lift the blood vessel away from the nerve.
No, okay, let me just paraphrase, because I was in a conference, and let me just paraphrase the question to you. Do you ever get patients with trigeminal neuralgia without compression of by a vessel, blood vessel?
I'm not sure. Maybe, can that be facial spasm? Because facial spasm is its own diagnosis too.
Okay, I just saw it in your slides, so I was just
Yeah.
following up some of the
Yeah.
causes. So anyway, thank you.
Yeah, thank you.
If you don't have more comment or question, Professor Kato, is possible you close remark?
Thank you very much. I think this is a great communication and question and answer. And I think just medical student and residents, their presentation is very high quality. And also the last question for her, no conflict vessel is a very, very difficult question, I think, for the beginner, I think. Anyway, I think the leadership as the student or resident is very, very important. So I think you can lead, of course, clinically or academically, or I think you can raise up your colleagues, not only yourself. I think it's very fundamental and important, and maybe you can have a more expand your community, so we can meet again and again. So it was wonderful. The first webinar with a student and resident, and just like usual conference. Thank you very much. I think it's very high quality. Congratulations to everybody.
Thank you. Thank you. The same. We like to sincerely thank all our speakers for their excellent presentation or discussion, for their valuable comments, and all the participants joining from the different parts of the world. I hope this first ACNS medical students and residents webinar marks the beginning of the long journey of international collaboration, friendship, and academic excellence. No? Thank you. And before the finish, I would like to invite us of the I would like to invite all of you of the 4th World Congress Young Neurosurgeons in Hong Kong, China, 30 October to 1 November. All of you are invited for attending or participating in this great conference. Thank you very much.
Thank
See
you for
the
this
next
great
session.
talk.
Thank you. Okay,
Thank
thank you
you.
very much for all commentators and the advisors. Thanks so much. Thank you, Raja and Dr. Liu. Thank you. Evelyn, it was wonderful MC. Thank you.
Thank you.